Good afternoon. My name is Dan Culver. I'm a lung doctor at Cleveland Clinic. I'm thrilled that you all are able to join us today to talk about diagnosis of interstitial lung disease, all is a hot topic at any meeting you go to. With new technologies, of course, there are new challenges and interesting data to review. We're lucky today to have two real experts with us. Rebecca Keith is an interstitial lung disease physician from National Jewish Medical Center in Denver, Colorado. And Jonathan Chung is a professor of radiology with an interest in interstitial lung disease from University of Chicago. We will have a discussion, case-based discussion today on several cases, and then we will have some time at the end for questions, I hope. Here are the learning objectives for today. We're going to look at the literature around MDD, especially as it pertains to ILD diagnosis. We'll have a special focus on HP. That's an area of interest for many. We'll talk about how the Envisia Genomic Classifier can be integrated into clinical practice and what this has to do with the concept of progressive fibrosing ILD. I believe Dr. Keith will take this first case.
Great, thank you so much. So let's start with the case. That's where all of our best learning is done as adults. So this is a 75-year-old woman, and she's a lifelong non-smoker, and she presents with shortness of breath and likely a dry, non-productive cough. And that's pretty typical for our patients who have interstitial lung disease. She was initially treated with a course of prednisone, but had only mild improvement in her symptoms, and she was referred to a pulmonologist. And so we see her, and we perform a further evaluation, including a high-resolution chest CT, which we'll look at in a minute. Her past medical history has hyperlipidemia and some chronic kidney disease. And we do a detailed occupational history, and she used to make ceramics and sprayed her ceramics with lacquer. And that should really pique our interest because we do know that there is some silica dust exposure, and lacquers can be associated with interstitial lung disease as well. She had a bird for approximately 10 years, but that was some time ago, about 10 years ago. And so in our mind, we're thinking, oh, another exposure, we need to be thinking about potentially hypersensitivity pneumonitis. And she routinely feeds her birds and refills her bird feeder, but that's outside. She has no mold exposure, no hot tub use, and her physical exam is notable for those dry bibasilar inspiratory crackles that are the hallmark of interstitial lung disease. We get some initial labs because we're being good detectives and we want to make sure that we consider autoimmune lung disease. And essentially those are all negative. We do pulmonary physiology, and we can see that our FVC is 43% predicted and our FEV1 is 55% predicted. And that's in a restrictive pattern, which we might expect in interstitial lung disease, and we were unable to get a DLCO.
So here's some HRCT images. So sequential axial images from superior to inferior. And so we look at the CT scan superiorly, and we see some peripheral reticulation and some ground glass opacity. Pointed out here, some reticulation here, a little bit of ground glass opacity as well. And we see more ground glass opacity and reticulation with a little bit of traction bronchiectasis as we get down to the lower aspect of the lung. Again, more of the same here. We see more fibrosis at the lung bases. So in the superior-inferior plane, it indeed does look to be inferior lung preponderant. In the axial plane, it's a little bit harder. I think up top, it looked like it was indeed peripheral predominant, but as we get down to the lower aspect of the lungs, it's not as definitively peripheral lung preponderant. And so there is some ground glass, but is ground glass the predominant pattern? It's really hard to say. So instead of me doing all the work, let's make you guys do some work. What is the HRCT pattern for this patient based on those CT findings? UIP, probable UIP, indeterminate for UIP, or alternative diagnosis. So we'll just let you guys vote there. Okay, so it looks like we do have a winner. It looks like most people chose indeterminate for UIP, and actually I think that's the way I would have scored as well. This is a hard case. So if we go back and we look at the images again, we see that indeed there is some ground glass opacity, but a lot of that ground glass opacity has superimposed reticulation on it. So it's hard to say, is there enough ground glass opacity for us to invoke this alternative diagnostic category? And what I like about this case is that this is a real life case. This is unfortunately the reality. Not all cases are textbook. And so if you look at the literature, anywhere from 1 out of 6 to 1 out of 8 cases, I think it's probably more like 1 out of 8 cases, even a skilled radiologist, thoracic radiologist who does a lot of ILD, kind of just throw up his or her hands and say, I have no idea what this pattern is. And so I do think that in this case, this is likely most best categorized as an indeterminate for UIP category. I do see why a lot of people chose alternative diagnostic category as well, and a few people chose probable UIP. But again, a difficult case, but it seems like the median really is indeterminate for UIP. So now let's talk about the 2000 ATS IPF guidelines. So as you guys know, it's not just ATS, but it's multi-society guidelines. So these guidelines, as well as the Fleischner guidelines for UIP imaging classification, exist, and they're more or less exactly the same. There's some slight differences, but I'm taking some liberties here. I'm more or less exactly the same. And because you guys are pulmonologists and probably read the multi-society guidelines more than Fleischner guidelines, that's what we're going to present here. And so we have a 4-tier system. So once you have an HRCT and you're able to figure out what the abnormalities are on that CT scan, so reticulation, traction bronchiectasis, honeycombing, things like that. And then you figure out the distribution of abnormality, both in the superior inferior plane, as well as in the axial plane of the CT scan. Once you figure out all those things, you're kind of like a cook in a kitchen. You have all the ingredients, you just got to put them together to figure out what the diagnosis is. And so once you have those things, you should be able to figure out whether it's UIP, probable UIP, indeterminate for UIP, or alternative diagnosis. And so UIP, I think most people are very familiar with. What is a UIP pattern on CT? It's peripheral basal predominant pulmonary fibrosis characterized by reticulation with subpleural honeycombing. So those cystic areas, which are in the most peripheral portion of the lung, which either line up in rows or stack upon each other. This is actually a beautiful example here. There's textbook honeycombing here on this left-hand image. The nice thing about that is that if you have a UIP pattern, you've essentially obviated biopsy, because over 95% of the time, if you were to biopsy these patients, you're going to get UIP and pathology. So no reason to actually subject those patients to an open surgical lung biopsy. Next category is probable UIP. The beauty of probable UIP is, and again, I'm taking some liberties here, but for essentially just for takeaway purposes, if you know what UIP is, you know what probable UIP is. It's more or less exactly the same, except there's no subpleural honeycombing. And if you go in with a high pretest probability of IPF, and you have a probable UIP pattern, I think a lot of academic centers and probably a lot of good community centers that see a lot of ILD, they wouldn't biopsy these patients as well. Maybe a little bit contentious there, but I think that there is still a high pretest probability of getting a UIP pattern on pathology if you come into that case with a high pretest probability of IPF before that CT scan. Our data suggests in patients who are over 60 who have a probable UIP pattern on CT, over 90% of the time, you're going to get UIP and pathology. So again, very, very high likelihood to have UIP in older patients. Next category is indeterminate for UIP. And so I love this category because in the 2011 guidelines, there is no indeterminate for UIP category. Essentially, there is no category for hard cases. So you had to get your case and you had to kind of pigeonhole it into a category that didn't actually make sense a lot of times, which would drive me crazy. Because I remember back in 2012, 2013, 2014, I just recently come out of training, and I realized that this pattern didn't fit any of the 3 classifications, but you had to kind of force yourself to try to put it into one of these bins. Now we have a category for these kind of hard cases where I throw up my hand and say, I don't know what this is. And it'd be interesting to follow these patients forward to see what actually the diagnostic ramification of these patients of this pattern is, as well as the long-term ramifications from an outcome standpoint. And the last category is alternative diagnostic category. And this really is a grab bag category. So these are essentially just a bunch of findings which don't jive with UIP. So if you know what UIP is, you kind of know what the alternative diagnostic category is. So instead of being peripheral lung preponderant, it's a central lung preponderant. Instead of being basal lung preponderant, is a more mid or upper lung preponderant in terms of distribution. Instead of having reticulation being really the star of the show with other findings of pulmonary fibrosis, is there just a lot of ground glass or consolidation or even diffuse nodular lung disease, things that really don't jive with UIP. That would draw us toward this alternative diagnostic category.
All right. So our patient here, we know that they have interstitial lung disease, but that's about all we know so far. We have a patient with some suspicious things in their history with exposures to a bird and who does ceramics, and then we have an indeterminate pattern on our CT imaging. And so when I approach patients with interstitial lung disease, I actually like to use the framework of the ATSIERS Guidelines for IPF. And I like to start, if I can make this little mouse thing work. So I suspect my patient may have IPF, but you could easily say, I think my patient has ILD. And so the first step is actually to identify potential alternate diagnoses or causes, right? Because if your patient, even if they had a real UIP pattern, has rheumatoid arthritis, by definition, they cannot have IPF. They are going to have rheumatoid arthritis-associated lung disease. So before we can move on to any other steps, we really have to behave like good detectives and try to figure out, are there any explanations or causes for our patient's interstitial lung disease? When I think about that, I try to think about what are the different types of interstitial lung disease. And certainly we think that there's over at least 150 different types of lung diseases, and it can get tricky to try to sort those all out. So I like to think about them in three main categories with a little bit of extras. So the first one are the IIPs, and certainly idiopathic pulmonary fibrosis is the most common of the IIPs. Then the other major class is autoimmune lung diseases. And the main ones we tend to see there are certainly rheumatoid arthritis-associated interstitial lung disease, systemic sclerosis, and also myositis or antisynthetase spectrum diseases. And the third main category is exposure-related lung disease. Certainly hypersensitivity pneumonitis would be the kind of hallmark of that. And so when I talk to patients and tell them, you know what, we look at your scan and we can all agree that there is interstitial lung disease, I try to break it down and keep it a little bit simplified and say there are three main categories we're going to investigate. One is the IIPs, or idiopathic pulmonary fibrosis. The second is autoimmune lung disease, and the third is hypersensitivity pneumonitis. Now, that's certainly not to kind of leave things out, another large category is sarcoidosis, and then there's a whole other group of other interstitial lung diseases that are listed here, like smoking-related lung disease, drugs-associated lung disease, vasculitis, and other rare ILDs. But I think this framework kind of helps us understand how we group these together and keep it a little bit more simplified. So how do we be good detectives? First is we start with a really detailed history and physical. And so we're going to ask lots of exposure-related questions, detailed work history. We're going to spend a lot of time doing a physical exam, looking for evidence of occult collagen vascular disease like synovitis, or kind of mechanics hands, where you can look and see that there's dryness along the kind of this part of the hand. And then we also spend time doing laboratory studies. And the main laboratory studies we're looking for, again, the most common things, rheumatoid arthritis, systemic sclerosis with an scleroderma panel, and then also our myositis-associated lung diseases. And in general, I don't just send a Joe 1. I tend to send a full myositis panel if I suspect that a myositis is present. Dan, do you do the same, or do you have a different pattern of ordering?
Usually I send the full thing if I'm suspicious. It is expensive to do the full thing, so if my index of suspicion is low, I might just use the more limited thing first.
Yeah, I tend to try to pick my laboratory studies based on clinical history, my physical exam, and then also when we look at our imaging, if there's any clues about what category we might be interested in. And certainly, Jonathan, do you ever see typical features of myositis or something that kind of clue you into maybe this is antisynthetase syndrome?
Oh, yeah, for sure. If you have a younger patient coming in and the major pattern is that of basilar consolidation, oftentimes with superimposed ground glass opacity, and especially if it has that morphology consistent with organizing pneumonia, whether it's parabronchovascular and subpleural consolidation, perilobular consolidation, or sometimes even frank reverse halos, it's really suggestive of a myositis, including the antisynthetase syndrome. And certainly the evolution of that, so once you get treated and the organized pneumonia component sort of calms down, oftentimes they kind of evolve into this NSIP look. That is like classic. It's like I've never seen that not be myositis.
Yeah, I would agree. That's our experience as well. And so once we get past identifying potential causes, and we did a lot of investigation in our patient, and certainly we looked for any type of collagen vascular diseases with our labs, and we didn't find anything. So we're going to head down. We did not find any other cause. Then we look at our high-resolution chest CT pattern, and it was not a definite UIP pattern. If it were, we could kind of skip right down to a quick multidisciplinary discussion and on to a diagnosis of IPF, but we have an indeterminate pattern. So we are kind of at a conundrum, and this is a great place where my team and I would get together for a multidisciplinary discussion, and we will talk about that in a little bit of future slides. And what the goal here is to kind of review all the data and think about what additional testing or ideas do we need to consider before we can move on. And in some cases, that may be a BAL or a surgical lung biopsy here. So we're kind of stuck here. This is the perfect time for us to get together and talk with our colleagues. So what is a multidisciplinary team? Generally, it's composed of a pulmonologist, a radiologist, and sometimes a pathologist, and we often have a rheumatologist on our team as well. And the way we run our multidisciplinary discussion is that we tend to use multidisciplinary discussion to talk about cases that are difficult. So those in the indeterminate patterns, sometimes that have probable UIP patterns, and certainly if the data that's in front of us has discordant information. So the pathology and the radiology don't agree, and then that's the opportunity for a really lively discussion. And if we think about the data for MDD, it's actually not great. It's low. There have never been studies that directly compare a single center or a single decision maker to a multidisciplinary team. But in general, if you look at the median agreement between diagnosis in either SDD or like a single deciding provider versus MDD, about if you look at 1,000 cases, in 700 of those, they'll agree, but in 300 of the cases, they'll switch diagnoses in a multidisciplinary discussion. So when you think about that, 30% or 300 of those, that's a lot of people where additional input may lead to a different diagnosis and therefore a different therapy. So I think in my own clinical experience, it's really helpful to bounce ideas off of other providers and get other takes on radiology and the history and physical I'm presenting. So Dan, how do you do your multidisciplinary discussion?
Well, I think that the multidisciplinary discussion has evolved over time. It used to only be reserved for making a diagnosis in patients with biopsies, and with the ascendance of radiologic diagnoses and more serologies and the understanding of the risks of some of the procedures, I think that now we often use the MDD at multiple stages during the diagnostic process. And so before a patient gets an invasive procedure, they'll have an MDD. And then after that procedure, quite frequently, that patient will come back. And then we also used it at times for difficult management decisions, which I think is not the classical use of it. And so, of course, with that sort of thing, you can't review every single patient at MDD. And so we only review a proportion of our patients, like you said, the ones who have difficult diagnostic dilemmas. I suppose that means, what do they say? You don't know what you can't see. So if you don't realize that there's a difficult diagnostic dilemma in front of you, you might not know to bring the patient to an MDD. But in general, those are the cases that we do. And certainly anybody who's entertaining any kind of bronchoscopic procedure or any biopsy procedure would have an MDD first. Is that similar to the way you do it?
Yeah, I think that's exactly how we do it. And we used to have face-to-face conferences, and now in the time of COVID, it's switched to Zoom, which actually made it more inclusive. And so we've been able to include some of our partners from nearby organizations because people can Zoom in. So that's one good thing that's come out of COVID, is that we've been able to increase the scope of our multidisciplinary discussion. Certainly, I bring cases where I have clinical questions before any kind of advanced procedure to make sure that I'm doing the right thing. And if I can avoid a surgical intervention or procedure for a patient, then I try to do that. And then when we have difficult kind of decisions about what to do next, or people who are progressing despite our what we think is our best therapy, those are great things to discuss. Jonathan, do you participate in multidisciplinary discussion?
We do, yeah. We have our conferences. We meet every other week, and so I think we do try to see most of the patients in the MDD setting. unless it's like, I think, maybe a home run IPF diagnosis. Otherwise, we try to get them on the list, and obviously those numbers can grow very quickly. Another thing we leverage is actually like temporally discordant MDDs. Right? So in other words, instead of having people actually talk on the phone or via Zoom, which can be difficult. Everyone's busy, so to find an hour where everyone can kind of meet at the same time can be challenging. But given that these are chronic lung diseases, and you don't necessarily need to make the diagnosis that day, it's not like an aortic dissection where you really need to know like yesterday if this patient has a disease or not. It can wait a week or two. So not uncommon for us to actually correspond via email, and that's been pretty beneficial as well to get things done in an efficient manner, given the fact that we don't meet every week.
What do you guys recommend, for our community partners? Sometimes it can be really challenging to get a multidisciplinary discussion together. And so in our institution, we've tried to, patients who refer a lot of patients to us may call me or one of my colleagues and say, hey, I really want this case discussed at multidisciplinary conference. And then we can either loop them in after or during the conference. But it can be a real challenge. Do you guys have any advice for our community partners?
I think that's exactly right. I think that having access to see which cases need to go to the MDD, it's not possible with the things Jonathan was talking about for every single case to go to the MDD. So sometimes a quick phone call or a 2-minute consult to look at some images and hear a history can be enough to be helpful. When somebody who sees a lot of interstitial lung disease still feels a little bit uncertain about the diagnosis, like the case you presented, then I think that's the case that needs to go to the MDD.
Okay. Let's move on to discuss the end of our case. So I'm going to move forward. So just to recap, this is a 75-year-old woman, and she's a lifelong non-smoker, and she has progressive shortness of breath. She did have a bird. She also worked with ceramics, and we're still have a CT that's indeterminate, so we do not have a diagnosis as of yet. Let's have another question. So what would we do next? Would you do a bronchoalveolar lavage alone? Choice B, BAL with transbronchial biopsies using the Envisia Genomic Classifier? Do you move on to a cryobiopsy? D, a VAT surgical lung biopsy? Or something else?
Before everybody votes for B, we might have thrown a curveball in here just because Veracyte's sponsoring this.
So when I think about this case, I certainly, given the indeterminate pattern and the bird history, even though it was 10 years ago, people can still have chronic hypersensitivity pneumonitis that becomes progressive and fibrotic over time, even with a remote bird exposure. I do think after a multidisciplinary discussion, I definitely would entertain the idea of going for bronchoalveolar lavage. And transbronchial biopsies, especially in hypersensitivity pneumonitis, can be helpful because you can see some of those granulomas because it's an airway-centered disease. I do think that in this case, there may be Envisia Genomic Classifier could be helpful, especially in indeterminate patterns. I tend to use it in my practice when I have an indeterminate pattern and I'm interested in if this could be IPF or not. That's probably the most common place that I use the genomic classifier is indeterminate patterns. How about you, Dan? What do you think?
Yeah, I think that's exactly right. There's some information coming out about that now that suggests that's a good place to use it. I think when you take a 75-year-old without a super strong smoking gun, like in this case, your pretest probability for IPF is pretty high right out of the gate. And so the genomic classifier is something that can help really get your confidence level up high enough for clinical management.
Yeah, it helps you move closer to that clinical consensus diagnosis. So hopefully in our patient, as we move forward, this testing will give us more information. So I think you're up next, if we can clear that. There you go.
Okay, so just a little bit about the genomic classifier. What this really is what might be called a molecular biopsy. And so this uses 3 to 5 transbronchial biopsy specimens, and these are sequenced to generate a transcriptional library of all the RNA across all the cell types that are gathered during the biopsy. And the way it works then is it makes a call based on all the transcriptional profiles of either yes, you have UIP or no, you don't have UIP. And we'll review what the performance characteristics of that are in just a second here. So this was really brought into use through the BRAVE study, which is actually a 3-study trial, which looked at about 30 sites, including about 450 patients who were going through a biopsy for interstitial lung disease. And these all were divided into ones who had surgical lung biopsy, ones who had transbronchial biopsies, and ones who had cryobiopsies. And then they were reviewed for central pathology, central radiology, and then subjected to an MDD. And those were then used, the biopsy specimens were used to generate this yes, you have UIP or no, you don't call based on computer algorithm. And then there were 2 independent validation studies, and you can see that there were about 150 patients between those 2 studies that then validated that classifier. So what they did in BRAVE then is they took this repository of clinical samples, they took the genomic data from the transbronchial biopsy, and they looked at how the classifier compared to the gold standard for this, which was the histology. And if the histopathology wasn't definitive or conclusive, then that case was not used in the BRAVE study. So these ones that are very difficult histopathologies, you have to remember, may not be, the genomic classifier may not be applicable to those. You can see here that there's a pretty good split. About a little more than half the patients in the BRAVE had UIP, and a little less than half had the things that we get confused about, including HP, NSIP, smoking-related lung disease. So those are the things we usually struggle with when we're trying to make a diagnosis of idiopathic interstitial pneumonias. So if you look at the performance characteristics of these, you can see that the specificity is always about the same across these 2 studies. That is around 90%. And sensitivity is a little bit lower, 63% if you pool all of these. So I think one important message that everybody should take out of this is that when you have a positive call from the genomic classifier, for this particular genomic classifier, the specificity is quite good, and you can have pretty good confidence that that's what you're dealing with. If you have a negative call, remember the sensitivity is only about 63%, so you cannot take a UIP pattern off the table. The other thing that I think is very important to know is that you are diagnosing UIP here. You're not diagnosing IPF. So other things that can cause UIP can be called as UIP by the genomic classifier. So we really look at this as a complementary test. This is one more tool you have in your toolkit to improve your confidence. Because what we're really doing in the interstitial lung disease diagnosis is we're trying to get confident enough about a particular diagnosis that additional testing is unlikely to be helpful for the patient, either for prognostication or for management. So you can just look at this algorithm. If you have suspected IPF, and you go through it the way that Dr. Keith said, if you end up with UIP based on the CT imaging, for example, then you're just done. If you have an alternative diagnosis, then there's a decent chance that a genomic classifier may give you misleading information, and you probably wouldn't go down that road either. But when you have the categories of probable or indeterminate, that's probably where you get the most benefit from this kind of particular technique. And it's important to remember that if it walks like a duck, quacks like a duck, and the classifier says it's a goose, you don't try to call it a goose. You're probably still dealing with duck, and you have to go back to your MDD and think about this some more.
Yeah, I think that that's important. I recently had a case that just went back to MDD, in which we did the genomic classifier in indeterminate, and you have to remember that 30% of the time on a negative result, at least 30% of the time, it can still be a UIP pattern if you go to surgical lung biopsy. And so it doesn't mean that you abandon that diagnosis of IPF just because you have a negative genomic classifier. It just means you have to keep working. So back to our case, this is our 75-year-old woman, and we did do a BAL. And so when we were doing a BAL, we look at the kind of cells that are living down in the lung, and most healthy lungs are full of macrophages. And in this patient, there are mostly macrophages and only about 9% lymphocytes. Now, there's lots of debate about how to determine how many lymphocytes help you make a diagnosis of hypersensitivity, pneumonitis, or inflammatory lung disease. People start to take note when it gets above 20%, and certainly take note when it gets above 40% based on the literature. But here, this is not a lymphocyte-predominant BAL, and she does have a UIP pattern on her genomic classifier. Her transbronchial biopsy did not show any evidence that there were granulomas, and it wasn't particularly that revealing. So I think in this case, we would make a clinical consensus diagnosis after repeat multidisciplinary discussion of IPF. Would you agree with that, Dr. Culver?
Yeah, I very much agree with that. I think the pretest probability was high, but it wasn't high enough coming in. And to me, this pushes you all the way up to a post-test probability that is pretty good.
Okay. Well, let's move on to our next case then.
Okay, so here's another case. This is a 77-year-old man. He's been dyspneic for about 5 years, but it's been getting worse recently. He's originally from India. He has some cardiac history, as you can see. He doesn't cough. There's no particular exposure history that could be elicited. He does not have any connective tissue disease symptoms and no reflux, at least not that he knows about. He smoked a pack a day for 18 years, but quit many years ago. He worked in a steel mill for 10 years, which, as you heard, should trigger some more questions from you. And there's no family history. His exam suggests crackles bilaterally, and there's no clubbing. You can see his pulmonary function testing here. He has a mild restriction on spirometry, but when you look at the plethysmography, he actually has preserved total lung capacity. You can see the diffusing capacity, on the other hand, is quite low. So you're automatically thinking in a fibrotic lung disease patient about a combination of an obstructive and a restrictive lung disease like CPFE. His serologies in this case were negative, but he does have some positive serologies for HP. And I just wonder, I'm going to ask you, Rebecca, how useful do you find HP serologies?
Yeah, I think that that's tough. I don't think that they're really neither sensitive nor specific, unfortunately. So it doesn't aid you in the diagnosis. The role when I use an HP panel, it's when I'm trying to get at what the exposure is, or if there's several exposures, trying to kind of figure out what's what. But yeah, I don't find them very helpful. How about you?
Yeah, I tend to do it once I have HP and I'm trying to look around for what might be causing it, sometimes as a real Hail Mary in a tough case, but most of the time I just skip it.
The hard thing is that in HP, up to 60% of times you don't even find an exposure, so it can be a challenge.
Yeah, I'm never sure about those series that find exposures in most of those cases. Those aren't the patients I'm seeing. Okay, here's the HRCT scan.
All right, so we have multiple axial images, again, going from superior to inferior. Just for those of you guys who have hawk eyes, you will notice that the trachea is somewhat malformed. But sometimes we'll see that in patients who have chronic cough. Sometimes you will get a little bit of tracheal abnormality, or sometimes just in the setting of tracheal malacia, the trachea can take on a lunate shape, which we are kind of seeing in there. But let's get to the star of the show, which really is the lung. And so bilaterally in the lungs, we're seeing ground glass opacity, which in the zonal plane, so that superior inferior plane, maybe it's a little basal predominant. Certainly looks like there's some more reticulation at the lung bases than more ground glass opacity in the upper aspect of lungs. So it looks like, bottom line, we have ground glass opacity in the upper aspect of lungs, with some even subpleural sparing, and at the lung bases, we have a little bit more reticular abnormality, but certainly a lot of ground glass opacity. So here's our next audience polling question. What would you do next? Bronchoalveolar lavage alone, bronchoalveolar lavage with forceps transbronchial biopsy with Envisia Genomic Classifier, cryobiopsy, VATS lung biopsy, or something else?
Okay, so it looks like most of the people picked BAL with transbronchial biopsy and genomic classifier, which actually is partially right. That is most of what we did. Before we get to that, I wonder if you want to go back, Jonathan, and classify this CT scan according to the ATS criteria.
Yeah, so according to the ATS criteria, with all this ground glass opacity, I think we would call this alternative diagnostic category.
Yeah, that's the way we were thinking about it too. It's a 77-year-old ex-smoker without a clear-cut other cause for interstitial lung disease. So your pretest probability for IPF is over 90% right out of the gate. But the CT doesn't fit very well. So this is again a very confusing case. So in fact, he did have a BAL and a classifier. You can see his BAL characteristics there. Still not a very interesting amount of lymphocytes, not too many polys or eosinophils. And the genomic classifier was in fact negative. So now you're in that category of, did I just miss the UIP with the classifier, or did I in fact actually find that there's something else going on and I need to go back to my MDD? In fact, what actually had been done for this patient was that he got an additional procedure. So what is your leading diagnosis now? Okay, so it looks like we're, well, NSIP, I think they took your subpleural sparing comment to heart, Jonathan. That's the leading one, followed by HP. And interestingly, nobody picked IPF, even though there's a chance of IPF being still present even with a negative genomic classifier.
It's still possible, though. I mean, to be fair, like you could still do a surgical lung biopsy, and that could be IPF. Even if you had an alternate diagnosis preferred, right, Jonathan, those still sometimes are IPF and UIP, even with a negative classifier.
Yeah, I mean, if genomic classifier aside, if you just look at the CT data, if you have someone with an alternative diagnostic category in terms of their imaging pattern, and you were to biopsy those patients, like 25 to 40% of the time it still comes back UIP. So it's not surprising. I think it's a minority of cases, but certainly there's a big chunk of those which come back UIP.
Yeah. So that's a great point. IPF is definitely not off of the table either because of the CT or because of the classifier. In this case, he had a cryobiopsy, and you can see this is a pretty nice sample. And we were fortunate enough to get some specimens that suggested chronic hypersensitivity pneumonitis. So you can see a poorly formed granuloma there. You can see lymphocytes wandering away from the granuloma, suggesting, again, that there's a interstitial pneumonitis. And you don't see the third part of the triad, the bronchiolitis, very well on this specimen. But in fact, this is chronic hypersensitivity pneumonitis.
Great.
I think that's now the key.
Yeah, so I want to talk about this new guidelines for hypersensitivity pneumonitis that were just recently published by the ATSIERS and ALOT. And this is really helpful because when we think about hypersensitivity pneumonitis, we used to classify HP either as acute, subacute, or chronic. And that is, there is a lot of clinical overlap between those, and it doesn't get at whether it was fibrotic or non-fibrotic. Certainly chronic or subacute could both be fibrotic or non-fibrotic. And so they reorganized these guidelines to just be either fibrotic or non-fibrotic, just to simplify things a little bit. And so, Jonathan, you want to talk about that?
Oh, yeah. And so we're not going to go into the nitty-gritty of the guidelines in regards to imaging, because that could probably take an hour in and of itself. But we will say that based on the imaging, HRCT really becomes much more important in this diagnostic workflow, because you got to figure out whether it's fibrotic or non-fibrotic, either on imaging or pathology. And obviously, it's much easier to get imaging and HRCT than to get a hunk of tissue from the lung. So CT actually becomes much more central to the diagnosis of these patients. So once you figure out whether they have a fibrotic pattern or a non-fibrotic pattern, you kind of want to figure out how confident are you that this is HP. And so here's our two typical examples of HP, and that is really the diagnostic buzzword, typical HP, in non-fibrotic disease and fibrotic disease, as shown in the left-hand column and the right-hand column. And so in non-fibrotic HP, the typical pattern you're looking for is really a diffuse process in which you're seeing a good deal of ground glass opacity. So on the top image on the left, you have this diffuse ground glass opacity with a central lobular granularity, telling you that indeed this is something that's probably involving the small airways there. And then on the bottom hand image in the same patient, on exploration, we see a large degree of air trapping. So that combination of diffuse abnormality, ground glass opacity, plus significant air trapping, a small airway disease pattern, is strongly suggestive of non-fibrotic hypersensitivity pneumonitis. It's pretty much a classic case. And let me show you an example of a classic fibrotic case in the right-hand column there. So the typical finding of fibrotic HP really is a combination of fibrosis in a particular distribution. So the distributions can be variable, but I think the classic one that we all think about is kind of that mid-lung distribution, mid-upper lung distribution of pulmonary fibrosis, or maybe a diffuse distribution with relative basilar sparing. Some people just call that upper lung preponderant. The guidelines sort of define that slightly differently, but I think a lot of places, when they say upper lung preponderance, they just mean the lung bases are relatively spared. And I think places I've trained would have described it like that. So having that distribution of fibrosis being atypical, so not consistent with a UIP pattern, and then superimposed on that, having findings of small airway disease, whether it's air trapping or some sort of central granular pattern that we saw in the previous case. So that's kind of what you're looking for in both of these cases, the non-fibrotic case and the fibrotic case. So
in this publication, it helps us with this kind of diagnostic algorithm, kind of what we've used for IPF in the past. And this can be a helpful tool to try to work through how to use the data. And so the first thing is that you look at a patient with ILD, and then you do a detailed exposure assessment and a high-resolution chest CT. Then moving on to a BAL with either lymphocyte, looking for lymphocytes and or transbronchial biopsies. So if you have a classic exposure and a typical HP pattern on your high-resolution chest CT, and you have BAL lymphocytosis, you're kind of done. You go and talk about it amongst your pals at your MDD. You may argue a little bit, but this can be a high-confidence diagnosis of HP. Unfortunately, this is not how it always happens. So sometimes you can have a combination of maybe a little exposure history, or you just have a HRCT that's kind of consistent, and then your your BAL might not be classic in your transbronchial biopsies. And so therefore your diagnosis is just unclear. And we spend a lot of time kind of reconsidering if there's any exposure. And remember that up to 60% of the time you may not have a clear exposure and you can still have hypersensitivity pneumonitis. So this is a great opportunity to discuss this case in multidisciplinary discussion, kind of look at all of your data independently and see if you can come to that high confidence diagnosis of HP. But many times we can't, and then in that situation, that's a great opportunity to kind of consider if you need a surgical lung biopsy. And some institutions perform cryobiopsy, and that we can kind of discuss as well. Our institution doesn't typically, we don't use a lot of cryobiopsy. We mostly would send this patient to surgical lung biopsy if we had a significant question. Then after that data was back, we had additional pathology. We would again discuss this case and come to our best clinical consensus diagnosis. It would be lovely if we had additional kind of technologies such as biomarkers or some kind of additional information that we could, one, risk stratify patients, either develop an initial diagnosis or be able to predict which of these patients might go on to have progressive fibrotic disease with our HP. There's a lot of things that we could learn from additional information moving forward.
Now the question is, let's say, and I think there was a question from the audience about this too, let's say that this was the HP case that we had by some pathology, and yet the genomic classifier was UIP positive, which we know can happen, right? We're just classifying the pathology. We're not classifying the MDD diagnosis. So what would be your treatment plan in this case? UIP positive, with HP?
So I still think that when you have a patient that has hypersensitivity pneumonitis, that there are significant inflammatory drivers for that underlying lung disease. And we think about ILDs in a spectrum of diseases from inflammatory drivers to fibrotic drivers. I think especially if you had a biopsy-proven hypersensitivity pneumonitis, most people at my institution would favor an immunomodulatory therapy first, and then over time evaluate for evidence of progression to consider either additional immunomodulatory therapy or an antifibrotic approach over time. How about you?
I think this is really tough.
Yeah.
That's exactly what we do. We'll try first a very quick-acting immunomodulatory agent. That means steroids, to see if we can get something really nice. Usually it's not very compelling, especially with HP. For some reason, the DLCO never seems to move very much, even when other things get better. And then quite often, especially if we have a BAL or imaging features or a pathology that suggests a lot of inflammation, we will use a steroid-sparing drug and go along for a while. And then I think the real challenge comes in the patient who continues to progress with the issue of whether or not you're adequately suppressing inflammation, or do you need to think about an antifibrotic agent if there's an element of fibrosis that's progressing?
I think it comes down, we would really love to have additional tools here to try to get at, or biomarkers to get at, what are the drivers of disease in a given patient or a given disease state. And we have hypersensitivity pneumonitis patients that are fairly responsive to immunomodulatory therapy, and then I have HP patients that are progressive and act more like IPF, and sorting that out up front is very challenging.
Yeah, these are very tough. I think HP is among the hardest. All right, so let's continue with another HP situation. So here's a 60-year-old female with progressive pulmonary disease. She was initiated on immunosuppressive therapy. Now she's had a decline of her forced vital capacity, and so she was brought back to the MDD. You can see here that there's a significant decrement in her PFTs, both in the spirometry and in the diffusing capacity. I don't know if you want to speak for a moment to the imaging patterns here on these coronal images, Jonathan.
Yeah, I mean, I think you can clearly see that after 12 months compared to the baseline, the lung volumes have decreased and there's more reticulation, there's more coarseness on that image, speaking to perhaps increased fibrosis in that lung or in the lungs. Also note that there is also superimposed mosaic attenuation, they pointed out with this arrow. Superimposed mosaic attenuation, these dark polygons, almost assuredly representing air trapping within the lung parenchyma, again, consistent with hypersensitivity pneumonitis.
Thank you. So this brings up the question of, would you say that this patient now has progressive lung disease? And, this is a hot topic, of course. And you can see here listed in the table 3 clinical trials, pirfenidone for unclassifiable disease, the RELIEF trial, which is, again, pirfenidone, and then the InBuild trial, which was nintedanib for non-IPF progressive fibrosing disease. And you can see that each of these categorizes patients a bit differently, both in terms of the time frame for progression, but also in the necessary metrics that need to be met to define progression. So you could say that the pirfenidone in unclassifiable ILD trial really probably has the strictest definition, because all of this has to occur over 6 months, whereas the InBuild trial is probably the most liberal. You have 24 months to see these things happen, and there are many, many ways to get it. And it's not just spirometry, actually. You can have a combination of worsening symptoms and increasing extent of fibrosis. So all of those, I think the differences and nuances between those are still being teased out.
Yeah, I just wanted to ask a question about that. So I think it's challenging that we don't to define progressive pulmonary fibrosis, since we don't have a strict set of criteria. And I think you kind of laid out the different options there. I was wondering, Jonathan, at your institution, are you using any artificial intelligence to read your CTs? Are you doing quantitative CT imaging to try to get at, is there progression or not? And how do you think about those tools?
We're not actively using it right now. I don't think many places are clinically using those things. but I think it obviously makes sense. It's going to be the name of the game in the near future. And obviously, the advantage of quantitative imaging, especially in the hands of AI using quantitative imaging, is that you get rid of the issue of intra-reader variation and even intra-reader variation. And also, it's the issue of seeing what we know. So I think, so Dr. Culver referred to this before. It's sort of as radiologists, we see what we know. And so we have this internal bias on how we evaluate these images. But I think that there's probably millions, if not tens of millions of data points on even a single CT scan. So maybe an unsupervised AI approach, an algorithm which can actually figure it out and look at those CT scans, it might be able to detect which patients have a higher likelihood to respond to therapy and maybe have better outcomes with certain therapies. But that's not in reality right now. But again, I think in the next 10 years, we're going to kind of see that sort of technology take hold.
Maybe, Rebecca, I can draw you out a little bit on this issue of PF ILD, no matter how you define it. Lumping and splitting, does it really matter anymore to come up with a firm diagnosis, or once you have fibrosis, it's just all the same thing and we should just be using antifibrotics? What's the difference?
So I love this question. People argue about this every which way. And so I think historically we were lumpers. Initially, everything was pulmonary fibrosis, and then we got really granular about things and that there's over 200 different kinds of interstitial lung disease, and now we're kind of back to being lumpers. But I think we need to find a balance, because I don't think that we should, in my opinion, I think we still need to do that detective work to get an initial diagnosis. I think it makes a difference for prognosis. Certainly, if you have connective tissue-related ILD, even a UIP pattern, your prognosis is better than if you have IPF in a UIP pattern. And our initial approach to therapy is going to be different too. I think the details come in as what happens over time. So you might think we have to be a little bit of splitters up front, but then we need to be really careful about following our patients over time and being vigilant to look for evidence of progression, and then be kind of thoughtful about what next tool you're going to use. And sometimes that next tool might be additional immunomodulatory therapy, like in myositis or in scleroderma or rheumatoid, and sometimes it might be a different type of therapy. So I'm still a splitter to some degree, although I recognize that there are common fibrotic pathways in all diseases. What do you think?
I agree. I think it's important to try to make a diagnosis. I think psychologically very important to patients if you can find something that you don't call IPF. I think that's number one. I also think that although there are common fibrotic pathways in the later part of the game, I wonder if the pathways are a little bit divergent earlier in the disease processes. And so, like you said, there are certainly connective tissue diseases versus HP versus other kinds of interstitial lung diseases that need various different treatment approaches. So I don't think mycophenolate, although I think in Denver you might think about this differently, we don't use mycophenolate for every single immunosuppressive patient, and I don't think we need to use antifibrotics right out of the gate for every single patient with fibrosis. So I really do think we need to tailor this. I think with better endotyping and more sophisticated artificial intelligence applications in radiology, we're going to become much better at precision medicine treatment for our patients.
Yeah.
There's one other thing I wanted to ask Jonathan, and by the way, for the audience, we have a few minutes left, and if there are any questions, please put them in. Jonathan, when we talk about progression of fibrosis radiologically, what do you mean by that? What do you think the kappa is for that, by the way?
I mean, the kappa just for initial diagnosis in radiology is okay. It's just moderate. Even if you compare expert to expert, kappa of around 0.5, maybe 0.6 if you want to be forgiving, right? I will say that pathologists also seem to have pretty high kappa for ILD as well. But certainly it's not a science, it's an art. It really is an art. If you see people who are really good at ILD and imaging, like someone like a David Lynch at National Jewish, and I've seen him firsthand diagnose things, it's an art. It's not like he's it's not like calculating things. Sometimes it's not just complete gut, but just figuring out how things come together, right? Pattern recognition, things like that. And so, yeah, I mean, I don't know, right? That's the best answer that I can give right now. When I think of progressive pulmonary fibrosis, I just think of, a little more reticulation, a little more volume loss. The problem is there is a lot of inter and intra-reader variation, and that's why I think at some point AI and quantitative imaging really is going to take hold, especially longitudinally in following patients. Also, just based on common sense, if you have someone with more severe reticulation, they're more likely to have progressive disease because at some point they had less disease, as opposed to we see patients come in with very, very mild interstitial abnormalities, very, very mild reticulation at the lung bases or in the lung periphery. Who knows what they have? Maybe they just have a little scarring. Maybe that is really a, quote unquote, pulmonary fibrosis, which is progressive, which over time will get worse. But no one really knows what these patients have. Now we call them ILA patients. No one really knows how to differentiate the ones who actually will progress over time and other patients who have stable scarring from, aspiration or infection or some other pulmonary insult. So a lot of work to do, but exciting to be an ILD.
I think the other thing to point out is that the progressive symptom category, not only do we have to pay attention to the interstitial lung disease, we have to pay attention to all of the comorbid things that come with having ILD. So cardiovascular disease and pulmonary hypertension, and those things can also cause people to be more short of breath when they're exerting themselves, and that it's not always their lung disease when patients are feeling more short of breath with activity.
Yeah, it's true. So there's a question here about whether molecular classifiers will change our categories for interstitial lung disease, or radiologic classifiers, we could say too.
So I wish, I hope so. I hope that our either molecular, so using proteomics, genomics, and also radiographic input from artificial intelligence will reclassify how we think about interstitial lung diseases, because if we could get at what are the drivers of progression in like a personalized medicine, precision medicine sort of way, I think we could be more successful about treating people and helping people stay stable or even improve. But I just don't think the tools that we have are there at this point. What do you think?
I think that's right. I think that it'll require large cohorts of patients with really careful phenotyping and then endotyping. Because endotypes can always be derived, but do they have any use in the real world? Are they helpful for how we prognosticate, how we treat patients? And so, you can't get away from real world data. Okay. Trying to see these questions. All right, I apologize. I'm having trouble seeing the questions. Can any of you see them better than me?
I can see, let's see here. Here's for patients in whom clinical picture, symptoms, imaging, demographics are suggestive of an alternate diagnosis. How do you decide between cryobiopsy versus transbronchial biopsy versus Envisia? And I'll add in here surgical lung biopsy. Isn't there a chance Envisia will be negative and thus the patient may need a second procedure? So how do you decide? So I think the question is, how do you decide on what your first procedure is going to be? And two, when do you decide if you need an additional procedure? Dan, what do you think?
Well, in our institution, or at least most of the people that I work with, we like to go into the airways once. So if you're getting a bronchoscopic procedure, we would not do a BAL and then come back and have a transbronchial biopsy. I will say that we've been doing cryobiopsy for about 3 years, and we just recently looked at all of our data and we decided to abandon it. We're not very happy with it anymore. And so just like you mentioned earlier, if you really have a lot of diagnostic confusion and it's difficult, then surgical lung biopsy is probably the way to go if it's elective. That being said, of course, we do very few of those. We think that we can usually get a pretty good diagnosis, and we don't need to do very many of those. Transbronchial biopsy, to me, I think is helpful for getting genomic classifier data, and for some very specific interstitial lung diseases. granulomatous lung diseases like sarcoidosis, diseases like PAP, some infections. But for many of the idiopathic interstitial pneumonias, for example, you would never make NSIP by transbronchial lung biopsy. There's just not a big enough sample. And so I think it has to be individualized.
Okay, so a follow-up to that is, what do you think that the value of BAL in routine use for an ILD diagnosis? Do you think that's helpful?
We've been trying to do that for years because the paper from the Essen group, Ulrich Costabel, and that whole group, and I have to say we almost never find that 30% lymphocytes they talked about. So we don't do it. Do you?
Yeah. No, we don't routinely do BAL. So generally when we're not sure, we don't have a clear diagnosis, we'll discuss it in multidisciplinary discussion. And generally, we will do a BAL before we go to surgical lung biopsy because it's a less invasive procedure, and sometimes we will get additional information. We may or may not use a genomic classifier, and generally, unless patients have a reason not to get transbronchial biopsies, just because, like you said, if you're in there, you don't want to have to come back. And then after that data, we will discuss again, and some of those patients, a subset of those, go on to elective surgical lung biopsy. Our institution does not use cryobiopsies at this point.
Do you do cryobiopsies at Chicago, Jonathan?
My knowledge, if we've done them, we certainly don't do them very often. It's definitely not standard of care here at University of Chicago.
So here's a question, Dan. Is the yield of Envisia better if the sample is obtained from a radiographic area that has specific features, and can radioprobe ultrasound be used in a high-yield area? So maybe it would be helpful if you want to describe how the procedure is done, because it's in a very specific patterned way, right?
Yeah, so yeah, the transbronchial biopsies need to be done from two lobes. Ideally, you get 2 to 3 biopsies from each of the two lobes. I don't know that the data really suggests, maybe you know, that targeting those to anything other than involved lobes is helpful. I know radial probe ultrasound was not used, or any other confocal techniques or anything to guide the transbronchial biopsies in that particular study. I think one of the advantages was that it doesn't have to be too targeted, the transbronchial biopsy. And although they, I think, would like the 5 biopsy specimens, I believe that the yield is still, or the ability to classify is still pretty good, even with just the 3 biopsy specimens. So if you get into a situation where you're in trouble in the bronchoscopy, you may still be able to get a good answer with fewer transbronchial biopsy specimens. Not that that's recommended.
Yeah, I think the neat thing is that there are gene expression changes that can be seen in areas that are not exactly in the area of fibrosis. And so that's why you can do these biopsies in like a pattern site and still be able to pick up this gene expression profile without having to biopsy right in the area of fibrosis, which makes it kind of a more helpful tool. So you don't have to be particularly, you can only buy, like if you're doing for HP that you want to get in a specific area or something. Let me see what other questions. So this, in terms of disease heterogeneity, can a single patient have multiple IPF subtypes?
In a single patient with, I'm sorry, I'm confused about.
Yeah, I think what they're saying is, how do we think about maybe disease heterogeneity or getting to a clinical consensus diagnosis? Can a patient who, maybe this is like, can a single patient have multiple IPF subtypes? So maybe I think the question is asking, if you have a UIP pattern, or sometimes if you have a patient that has IPF, can you sometimes be wrong? And the classic example I would say of this is that we often find that collagen vascular disease like rheumatoid arthritis can present in the lung before anywhere else. And so we may initially classify someone as having a UIP pattern in IPF, but years later they develop a fulminant autoimmune disease. And so this can still be tricky. What do you think about that?
Well, I think you're just making the gold standard in this was the histopathologic pattern. So this diagnosis UIP. This does not diagnose IPF. IPF is still a diagnosis that happens in a clinical setting in correspondence with the radiology. So as far as different histopathologic features of UIP, and you know that there's a long discussion about that in the guidelines, I don't know that there's any different behavior, and I don't know that that was really tested, particularly in the BRAVE study. So I think if you have a UIP pattern that's called confidently by pathologists, that was the gold standard, and that's what was used to develop the derivation set. I thought maybe they were asking about the old issue. If you have NSIP in one lobe and UIP in another lobe, how would this call it? And I think that those still behave as UIP, and so this would still call UIP, to your point.
Yeah. All right.
I think we probably are up against it on time now. So I want to thank everybody who joined. We had a very nice group of questions. We almost could have had another hour here for questions. So thank you for all of your interest. And thanks to you, Dr. Keith and Dr. Chung, for joining us this evening. Everybody have a good night.
Thank you.
Night.
Take care.